So, just as kind of a background and to set the stage, I'm a spine surgeon, board certified here in Dallas, Texas. This is the same area I grew up. I'm from, went to SMU, and then left for about 10 plus years to do advanced surgical training. And now I practice here in Dallas, Texas. I don't want this to be an advertisement or anything like that. I more so just jump on here for about 20 to 40 minutes every now and then on the weekend to just answer questions about spine surgery, spine anatomy. It's been really helpful for both my patients as well as people I know just kind of get their questions answered. So look, here's a little anatomy review. It goes bone, disc, all the way down the spine. And to answer different questions about the spine, I think understanding the anatomy is helpful. So I'll kind of just jump into a bunch of different questions. I know I have a lot of people here. I appreciate all the follows, likes, shares that helps promote this to your peers. A couple questions coming through, and then I'll kind of talk about different topics. One of them from Mady, that's a great one to start with. What's the difference between spondylosis and spondylitis? Spondylitis is essentially the back part of the spine having a lot of inflammation. These joints in the back. It could kind of be the disc space, but really it applies mostly to the joints. That's what the spondylitis. Itis is like it's an inflammation. Like when it's itis, that means inflammation. So that's usually what itis stands for. Spondylosis is a little different, and you can get different forms. Essentially, if you have something called like spondylolisthesis, which I know is not 100% the question, but spondylolisthesis is when this bone slides forward from severe degeneration in the joints here, whereas spondylitis is inflammation of the joints. Momo, thanks for following. Daniel, thanks for following. New Academy, thanks for the follow. So let me kind of jump to a couple more questions I'm seeing here. So after fusing the C6, C7 together, I had pain in my left arm. Will that go away? It might. Usually that's the C7 nerve. The C7 nerve goes down this part of the arm. You just kind of into these joints, these fingers here. Linda, thanks for the comment. I appreciate that. From T said, do you know what this might be? I think I missed your earlier comment. Kathy, thanks for the gift. You don't have to do that. I say save your money, give it to other people to make money for a living on social media. A couple other questions is what is spondylolisthesis? We kind of just went over that. And what's a pars defect? So from Landon, you're talking about my favorite topic, and that's spondylolisthesis. Essentially, that's when you either get it from severe arthritis in the joints in the back or a fracture in this part of the back. And that's when the bone slides forward just like that. That leads to an accelerated wear out of the disc space here. Once this disc space wears out, squeezes down, squeezes that nerve, numbness and tingling down the leg, down the arm if it's in the arm. So that's essentially what a pars fracture leads to that would eventually need surgery. From Gerald, do I do telemed? Yep, all the time. Another question is, do injections help? Do injections help that pars fracture? Kind of. They can help the pain associated with the nerves being pinched. Definitely. We're in Texas. I'm in Dallas. A couple other questions I'm seeing. Do I use neuromonitoring? I use neuromonitoring probably for every single spine surgery I do. There might be maybe like a kyphoplasty in the lumbar spine. I might not use it, but it's kind of a industry standard in the region I practice. To be fair, it could be overkill. Not, if I was getting a spine surgery, I'd want neuromonitoring, but sometimes insurance companies don't pay for it, and I guess the hospital eats the cost, I assume. But neuromonitoring essentially is when you get a bunch of needles hooked up to your legs, arms, and even brain during surgery, and then the spine surgeon can watch your nerves throughout the case. And some people don't use it. I use it pretty much for every single surgery. Why not? Okay, kind of doing a couple more things here. Let me get some more of these questions. Thoughts on SI joint fusion from, I think it was Morgan. I don't dislike SI joint fusions. My recommendation is that's a spine surgery. And I know this sounds silly, but if you're going to have spine surgery, I would allow a spine surgeon to do it. There are pain management doctors who can do that surgery for sure. I'm sure there's some that are really good at it. My recommendation on having a spine surgeon do spine surgery is purely based on the fact that they've done surgical training on hundreds and hundreds of patients, and they know how to deal with complications. They also know how to deal with other conditions that might not be associated with SI joint fusion. They know how to deal with this if it gets infected. They know how to deal with if it's some other part of the spine. So I think it's critical to have spine surgeons do spine surgery, not pain management doctors who maybe just did a weekend course on it. From Southern Flow, Doc, the congenital isthmic spondylolisthesis cases that you see, what percent tend to fare well with conservative treatment versus require fusion? Okay, Southern Flow, that's a good question. Part of it is maybe we don't know. Um, People that are born with it, like this slip here, there's probably a lot of people out there that are born with it, living with it, and we actually don't even know they have it because it's asymptomatic. But the majority of people that have it as congenital do need a fusion surgery. That's different than isthmic, where you get the fracture in the back. That's definitely not the majority of people that need surgery. The people that need surgery from that condition, that's when these bones are slipping forward, is when this disc space is completely worn out and it's squeezing the nerves. It's a fantastic surgery. There's a lot of different ways to do it. Really, the reason I think I love doing it is not even because of me. It's because I think I have the best vascular surgeon in the nation. She's the highest, probably, in the highest volume of anyone that does that procedure, the approach. And so I can put in these big, nice spacer cages because it's so safe when I use her skill set. A couple other questions is great. I know, yeah. Okay. So from I wish I was the Rose King. I don't have the answer to your question, so I'm reading this as I go. Do I have issues with an A-lift cage migrating anteriorly? No, I don't think I think I've seen that one time. There's just you get a little something called subsidence at S1. So you have your cage here. Maybe this fractures. The S1 could fracture, it could subside, and then it shifts a little. Pretty rare. I think I've only seen that one time. The reason is like the cages I use have these little blades or screws that go through them, and so they're kind of locked in, and there's nowhere for them to go. And then I usually put pedicle screws in the back, so it'd be pretty unusual for that to happen, honestly. It'd be pretty tough. A couple other questions. What are you supposed to feel during an epidural injection for a disc herniation? Well, you could be asleep and you feel nothing, which is great. You could also feel the pain from the needle or the pain from getting to that nerve. From PILI, are the screws and cages used in spondylolisthesis all the same quality? No, but I wouldn't. I'm not saying some are bad quality, Pilly. I would say, look, some of these could be these 3D printed titanium cages, and this one's from Evolution Spine. That's a really slick cage. But some people use cages that are plastic. They're called peak cages. Fine. I don't love peak cages, but fine. You could also get cadaver bone. Cadaver bone's fine. I think there was a time period cadaver bone was great and it's still good. I don't know. I don't really want cadaver bone in me if I don't have to have cadaver bone in me, but cadaver bone's still good. So there's just different technologies to use. The one I use all the time, and I'm not saying someone's wrong to not use it, is kind of this 3D printed titanium. I like those for a lot of specific reasons. Why don't I like peak cages? Well, peak cages are it's almost like cars. There's like 100 different types. You can have titanium coated peak cages. You can have first generation. You can have peak where it's PEAKE versus PEK. I think it stands for acetylcholine, or I forget what the A stands for. It's a big fancy organic chemistry word I had to learn at some point. Either way, there's just a lot of variability in those cages. And I like the while the plastic's good, they don't induce bone stimulation. They don't induce bone to grow. A lot of people, surgeons, use them because they don't really show up well on X-ray, and so if they're not perfectly placed, no one really knows. It's fine. That's not like the best defense to use them. I know that sounds ridiculous. Whereas titanium, it shows you exactly where that spacer is. So I like titanium. In training, we use a lot of cadaver bone. Cadaver bone's fine also. It's just based on maybe what your community resources are, what part of the world or country you're practicing, and just the technology that different providers have. A couple questions from Kelly Jordan. Can you find sources of pain? So far, no luck. Sorry. I hope you find your source of pain. One person saying, should I include alien abductions in my history? Maybe. I think people used to think that'd be laughable, but modern times, maybe that's a real thing. From Tomcat, you hear about the issue with bone graft or it's contaminated material. Yeah, I think that happens every now and then. There was one thing where maybe there's like a tuberculosis exposure. If I have to think back to it, it wasn't any product I used or ever used. I think I just remember seeing the headline on it. So Tomcat, if you want to send that story, I kind of remember something about that, but I don't know. But yeah, that's also part of the whole cadaver stuff. You're relying on those testing systems to make sure it's not contaminated with any human pathogens. So look, and there's certain insurance companies like Aetna and Cigna that essentially only approve cadaver bone, and that's kind of crazy. Think about the tens of thousands maybe even hundreds of thousands of dollars you're paying for insurance, and then the insurance company like Aetna or Cigna says you have to have cadaver bone for the spacers. I don't know. I feel like if the surgeon wants to use a certain product, they should be able to use their product. They shouldn't let the insurance companies dictate care. Again, no one cares what I think. I could go on CNN or Fox and preach all day. The insurance companies legitimately make billions of dollars a year. They don't care what we say. A couple other questions. Carla is asking if I'm in Fort Worth. No, I'm in Dallas, the same place I was born and from. From Tomcat, Aetna unlikely to approve Intracept. I don't know. I don't do the Intracept procedure. I have a pain doctor in my group. She does the Intracept procedure for a long time. The Intracept procedure I think it's a pretty good procedure. It's a very minimally invasive, small little stab, like with the needle incisions through the back muscles. They put in a kind of a hot laser. I hate using laser because I think that's such a marketing ploy. There's a hot probe in the bone, and they burn the nerves inside the bone. It's kind of a good source for back pain for a very narrow indication, but that's a good way to go about it for certain conditions. A couple other questions from Timekeeper. Our health is not a priority to insurance companies. Yeah, I agree. I don't know if it's ever going to change. I don't pretend to have the answers, but really the health insurance corporations, they're getting government handouts, they're getting government money all the time, and they're not, they're making billions of dollars. It really makes no sense to me. But there's really nothing I can do. So I'm just gonna keep going onward. From Sam Theo, hi doc, I got a laminectomy and a fusion at 5'1", and now the pain is constant and worse. Well, Sam, it could be from the nerves just getting a little irritated or overstretched during the procedure. It's a little hard to say with just that information. From Manny, what's your thoughts on the mild procedure? I've pretty hot takes on the mild procedure. So mild, capital MILD, is kind of one of those things that was probably invented by spine surgeons and now done by pain management doctors. Look, most spine surgeons are gonna do like a real microdiscectomy or real laminectomy. They're gonna do like a real procedure. The mild is essentially making a small incision on the skin and like shaving off some of the tissue. It's just like like the overall majority of patients need more than that, but it sounds really great. One, it's called mild. Ooh, that sounds great. A pain doctor is very likely doing it in a surgery center they have ownership in, and they're very likely, it's one of those things that can't do too much harm, to be fair, because they're not doing too much, but it delays care, it gives patients false hope. I'm not against it if a spine surgeon is doing the mild procedure. This just goes back to the earlier thing I was arguing that I think if you're doing spine surgery, you should be a spine surgeon to do spine surgery. So the mild procedure, I'm okay with it unless it's a pain management doctor doing it. I just kind of think again, spine surgeons should do spine surgery, just like I don't do heart surgery. Heart surgeons should do heart surgery. Sounds pretty obvious. Question from Blue Ridge. My daughter is here asking about upcoming surgery. Her name, and then they say the name. Uh, So that's good. I don't know what the question is. I must have missed it. I'm sorry. Eric has a question. He says, I had an S1L4 lateral with bone grafting revived from a one incision tunnel. Sorry, man. I'm reading that up pretty fast as it comes, so I just don't know what it means. If you want to keep typing it again. Okay, a couple other questions here. One is from Southern Flow. He or she keeps asking a question that I love talking about, and that's this medical word called spondylolisthesis. You might see that on your MRI or X-ray. I think I'm extraordinarily good at fixing it, and part of that confidence, I don't think that's a bad thing to say, is that I just have an extremely good vascular surgeon, and she really takes away so much of the risk and worry and has just such a reproducibility on to fix that. So I love talking about it just because I legitimately really enjoy fixing it. And that from Southern Flow is asking, does the level of the isthmic spondylolisthesis have anything to do with prognosis? Is it worse or more unstable at 4 or 5, and they tend to evolve the same? Man, that's like a really upper level question. Um, how about this? Most isthmic spondylolisthesis, I think about 80% of them happen at the lower L5S1 level, whereas the degenerative type usually happens at L4, L5. That being said, I don't know specifically if one level leads to more surgeries than the other. Again, there are more um, of them happening at 5'1" just because 80% of them are happening. So I don't know if the prognosis is worse or better at one of the levels. some of the prognosis is just based on what the disc spaces look like, how this instability is, how it's moving. So there's really a whole lot that goes into it. I don't know if it's different between 4.5 and 5.1. I'd really have to look at that. But I think that the surgical outcomes, regardless of level, are extraordinarily beneficial, but it also depends on what technique is used. Do you go through the front? Do you go through the side? Do you go through the back? And Justin, what's your opinions on doctors' patient after surgery? I don't know if I don't not believe it. It's had surgery. A pain doctor should prescribe pain medication. So that doesn't 100% make sense to me. I guess there's millions of surgeries that happen each year, but I would like to think that most doctors give out pain medication for a little while after surgery. So I just don't have the answer. Couple question: why do spinal issues cause a UTI in women? I don't know if that's 100% true in terms of one versus the other. Women are more likely to get a UTI, but I don't know if that's 100% correlated. From Kim, to answer your question, no, I'm not. From Sherry, do you know anyone in West Virginia? I don't. But Sherry, I do this one in Pennsylvania. If you want to go to Philadelphia, one of my best friends, a guy named Jose Canseco, and that's not a joke. That's actually his name, Jose Canseco. People see me looking off screen every now and then. I got a couple of these college football games going on right now, so I'm peering over to those every now and then. From Farrell Lewis, what is spinal stenosis? Well, that's a great topic. And again, I appreciate all the likes, follows, all the comments coming through. Those are really helpful, and I'll try to get to those. So, kind of looking down the tunnel of the spine. So, this is your spine. This is the neck, or pinching your lower back. You know what I mean? So, here's your spine. Looking down the tunnel of your spine, Farrell. These are all the nerves run down this tunnel here. So, same argument here. Here's your spine. Looking down the tunnel, right there. When those nerves all get squeezed around here, get tight. So, if it's all open, you get squeezed and tight. That's what causes spinal stenosis. Um, what does Jose practice? He practices at the most famous spine center in the entire world. He practices at the Rothman Institute. It might not be a household name, but anyone in orthopedics has known about the Rothman Institute since before, I don't know, maybe when they're going to med school, whenever you're in your infancy. So Jose Canseco at the Rothman Institute. He's the most famous place in the world. Okay, a couple other questions. So sorry. So for spinal stenosis, that's something I treat all the time. I see a question. Can you diagnose that? Telemedicine. Kind of. You know, the thing I do 30 telemedicine appointments a month or a year or sorry, a week. I don't want this to be an ad for that, but this is something where that's probably about 30% of all patients I see are telemedicine, and that's a great benefit of COVID. It made us more accepting. That's the only benefit of COVID, really, to telemedicine. I need X-rays and MRI. Happy to discuss more. Kind of looking down the tunnel here, looking down the tunnel here. That's what squeezes those nerves. You can diagnose it on a clinical exam, but you can also diagnose this talking to the patient. You can diagnose it extremely well from an MRI. That's where the nerves are really squeezed. From Kiss My Grits, that's kind of a funny name. What is a vacuum disc? Pretty much if you have disc spaces, you go bone, disc, bone. These disc spaces, when you've lost so much disc material, it's gas. It's actually nitrogen gas, and that's what kind of rubs this, and it's bone on bone. Ricardo, thanks for the follow. I appreciate it. Jamie has a question about telemeds. Again, I don't want to be an ad. You can just direct message me, anybody, and I can have my office. They send you a template on how to do your telemedicine appointment. Pilly, I'm sorry to answer, or sorry to not have an answer your question about London. I really don't know any doctors overseas. I know one guy in Australia and a couple of guys in South Korea, but that's about it. I apologize. Someone's asking what's out of my hand. Well, this is a pedicle screw. So Tomcat, to get to your question, if you have spondylolisthesis, should you forgo the Intracept and just do a disc replacement or fusion? How about this? If you have spondylolisthesis, you can't get a disc replacement because that you need 360 degrees of stability, so you can't do that. I don't hate the idea of doing Intracept. Look, it's always better than the bigger surgery, but if I was you, kind of half joking, I'd try to do them in the same calendar year because it'd be terrible if you pay all this money for this lesser thing and then you get to January and now you got to pay all this money for your surgery. So look, I'm half joking when I say it. I'd try to do it sooner than later, so that way, if the Intracept doesn't work, if you're still in pain, then you've already hit your deductible. And we're kind of getting that time of year. That's an important thing. The amount of money these insurance companies take from you, you might as well take advantage of it. And I think that's an important part of someone who, I have private insurance myself, and it's stupid expensive. It's crazy. So I do feel for patients. Someone's saying a question says from Eric, don't do foreign hardware on a misspelling of spondylolisthesis. Use your own bone grafting from the iliac. Eric, back in the day, maybe in the early 90s, before we had pedicle screws, we actually would do it's called in situ fusion. So again, you have this instability there. Well, what do we do before all this technology? Make an incision, we burr off this thing, we harvest bone from your hip, you're right. We lay that bone down there. Okay, that was great at the time, and we thought it was pretty darn good. And we had an okay acceptance of a 30%. So 1 in 3 patients have chronic pain from that graft host site. Either on the front, if you get a donor graft harvester, 30% of people have chronic pain just from that harvest. So, okay, cool. You maybe healed the fracture, but now you gave someone 30% chronic pain rate from doing that. So we don't really do that as much anymore. You can see that's a dumb idea. Two is these didn't always fuse. Not using these pedicle screws, just using the bone, just laying it down there and crossing your fingers and hope that it fused didn't work that well. It worked okay. And again, before we had these pedicle screws, cages, all that stuff, it was a good idea. So saying not to use foreign materials and to harvest it from there, you're right. Go for it. You can try that all you want. I just think you're really running the risk of some chronic pain and maybe needing a second revision surgery. But that's how we did it back, I'm guessing, in the 80s, 90s, and the majority of them were fine. 60% of patients didn't have chronic pain from the harvest site. That's higher than 50, I guess. And I don't know the exact fusion percent back and doing it that way. I'd say maybe 60%, 70% fused just fine. But that's just a whole lot of patients where they don't get better with surgery. And that's why when you hear someone, oh, my grandfather got spine surgery and didn't get better. Well, back then we weren't using pedicle screws. Back then we weren't using cages. So there's just different technologies that fortunately we live in a time period where we have that stuff. From user, a bunch of numbers. Is recovery hard after spinal stenosis surgery? Probably. It just depends on what that surgery is. Is that an outpatient laminectomy? Is that a fusion? Is that a 360 fusion? That just the pathology doesn't always dictate the treatment. So you can have a certain condition and there's different treatments for that. I actually just posted 2 different videos yesterday or today. I kind of forget in terms of the timeline of when I posted it about recovery from both spinal fusion and spinal stenosis. I appreciate all the likes going through. Appreciate the shares. That really helps promote this to your peers. Kind of get out the good word. So the more likes and shares and follows you guys can hammer that, we can get up to 5,000. That would be really great to kind of keep preaching the good gospel and make my weekend worth it. From Mighty Mo, how do you know if you're a good candidate for surgery? It's really a lot based on your X-rays, MRI. But the other things that are pretty important is to know you failed non-operative, failed conservative treatment options. Then we know that you'd be a good candidate for surgery. Shooting down leg pain, numbness and tingling in the thighs, those are also things that are really helpful. Just kind of reading a couple texts coming through right now. Really good question coming in. See this one from Sam. Sam says, L5 fracture, right side, T as an athlete, 3 months of PT unsuccessful, condition deteriorating. What is the surgery? Sam, I can't give you formal advice, but I guess, are you still a teen athlete? Or are you saying this was like, is this a current thing or this happened in the past? If you're still a teen, there actually are certain non-fusion things you can do. Actually, it's just like that one bone fuses. Um, it's a really long thing to describe, and it's kind of based on your condition. I don't like doing this surgery, but one of my good friends in Miami does it all the time. But it's a small incision. You put these screws through the bone. It only works in kind of fresh fractures, maybe people that are 15, 16, 17, maybe 18 years old. And that way you can it's called a direct pars defect healing. And that's always a good thing to try. So that could answer your question. There's also certain bracing you can do. From Amanda, how long have I been a surgeon? That's right. I guess it depends on what you define as surgeon. I guess my residency started in 2014, so 10 years ago. Does that make me a surgeon? Is that when I started residency? Yeah. Okay, 2014. So if that defines starting of being a surgeon, I'm in my 5th year of private practice, though. If that answers your other question. Okay, a couple other questions. What could cause spondylolisthesis in a healthy teen athlete? Very likely, it could be a pars fracture on the back, hyperextension, and having this instability on the bone. Very could be likely. Okay, appreciate all the likes and things coming through. I will try to answer these as quickly as I can. There's a lot coming in from Southern Flow. Another good question. Have any of your isthmic spondylolisthesis patients returned to sports or athletics? Universal restrictions, post fusions, or all case by case? Um, if you had a pars fracture and had surgery for it, you could 100% go back to almost all sports. It kind of depends on what it is. Are you talking about like pro football or one level spinal fusion? For sure. There's no reason, maybe you missed that season. I'd probably want someone 6 months, maybe 9 months before they went back to NFL football. It's a little case by case and kind of what the images are. So yeah, there's no reason, fusions sound big, they sound scary, and they're a big deal. But one level, two level fusions, there's no reason you shouldn't be able to go back to skydiving, rock climbing, marathon running. Like, you're just fixing the two things. Tomcat, thanks for the comment there. Some of those editing I do on my videos take forever. I kind of proudly say I do all my own editing, recording, and all that stuff, and it takes a whole lot of time. But I think it adds just a tad more authenticity than just outsourcing it and kind of other providers out there just trying to make money on it by paying someone else to do it. I think, it's my work. I like to do it myself. I think that's a big deal. But yeah, it takes forever, and sometimes it's painful if the video fails and doesn't do well on views. Not like, well, that was a dumb video. Okay, a couple other questions here, and I do have to go. I got those my followers, subscribers know usually when I jump on these things, I have one of my kiddos taking a nap, and if another kiddo's not taking a nap, he's maybe playing on his phone or iPad, and I don't want to do too much of that, but he deserves a little break every now and then. I don't know Dr. Dre. I've never met him, but I'm flattered you would ask. But he's probably the most famous doctor. I'd love to hear. Actually, I know someone that answered that question. They said, "Who's the most famous doctor in the world?" in their medical school interview, and they said Dr. Dre. I thought that was a really impressive answer, and I was like, tip my hat to that person who said that, if they really said that, of course. From Julie, I have an L5S1 herniated disc. An ortho surgeon said disc replacement. Two nurses and no way. I don't know the answer to your question. I'd have to know a little more. In general, if you have a disc herniation, you could probably just do a micro discectomy. Doing a disc replacement for a disc herniation is like dropping a nuclear bomb on a city with one bad guy. You're creating a lot of collateral damage. From user, a bunch of numbers. Can I get a titanium spine? You can. I don't know if you should. From host Johnny, what do you think of tops for fixing a 3-4 spondy? I don't know, man. I might be on the wrong side of history on the tops stuff. I'm not a huge fan of it right now. Maybe in 5, 10 years from now, I could be more of a fan of it. I just think you're doing a whole heck of a lot, and a lot of it seems marketing. I think a lot of studies show that one level fusions do well. You can also do ablations. There could be lesser things that are coming out also. You don't need hardware like an endoscopic medial branch transection, like just cutting the nerve to that joint. Do you really need to replace that joint? There's a lot of answers there in terms of the tops. Look, I'm not gonna. If one of my colleagues is doing tops, I'm not gonna publicly make fun of them, but I'm not there yet in my practice pattern to be experimenting on my community. But if other people want to take your cash and do that surgery, and you want to go pay $30,000, $60,000 because you're so afraid of a surgery, so afraid of a fusion, then that's why you earn money to have that ability to do that, I guess. A couple other question is a facet replacement. Okay, so Dante, I kind of just answered that question, and it's just I don't know, Dante. I'm not on the fence. I'm just not there yet, and I hope I'm not on the wrong side of history on it. But it's just something where, again, if you have cash and you want to pay cash for something, you can always find someone to do something on you. I would just love for a little bit more to come out on it, and I don't want to too much go on the record. From Brian, 30 to 60,000, you can go for Germany and get a disc replacement for cheaper than that. God, I'd hope so. I always heard 60,000 was the going rate to go to Germany to get a disc replacement, which I thought was super stupid because most of these disc replacements are covered by insurance if they're indicated. So then you're just paying your deductible. I saw a patient the other day. He might be watching right now. I'm not going to give any information. He's not from Dallas. He is about 9 months post-op from a lumbar disc replacement. I'm not going to say the level, and he's doing terrible. He paid almost $100,000 and went to California and had one of the famous guys in California do it. But the guy had way too much arthritis. I have a CT both just after the surgery and before the surgery, and it's just terrible. Like, that doctor is cash only, and so if the guy needs any other surgery, he's got to pay another crazy amount to that doctor. Like, it boggles my mind a little. I'm not going to out anyone, and it happens, I guess, but I just kind of warned someone on paying cash for surgery sometimes. So I'll just kind of leave that there. And I do think we have a really reliable plan to get the patient better. And I'll probably post his case once I get about 6 month follow up or 1 year follow up. Because, I could post 1 day follow up and say he's doing great, but that's stupid, right? Like everyone's, not everyone does great day zero, day one, day two. It's really the longer term outcomes. So I have to be patient on that one and just hold my tongue, which I haven't done well. Don's asking about stem cell therapy. Don, I'm going to preference this statement by saying, look, I could do stem cell. I'm a spine surgeon. I could do stem cell therapy in 1 or 2 weeks. I'll probably have to go to a course, maybe get a license. I don't know if that's true. And then I can start doing it. I could take your cash because it's cash only and do stem cell therapy all day, right? Fine. I don't like stem cell therapy for the spine necessarily because no studies have shown that it regenerates cells or it reverses aging. It does decrease pain, so do epidural shots, so does even PRP, to be fair, and those are covered by insurance. Stem cell therapy is not. So I say if you have a ton of money and you want to go burn $5,000, $15,000 for stem cell therapy, fine, really fine. But I shouldn't be the bad guy telling patients the truth because I'm not doing it. And they're like, "Oh, you just want to do surgery." Look, I would make more money doing stem cells and not doing surgery. And patients, what's the worst thing that happens with stem cells? Oh, you don't get much better, and then you do surgery anyway. So that's my thoughts on stem cells. People think it's a little controversial. Maybe that'll probably change one day. Stem cells, that's such a broad term, right? I'm sure I'd like to think in like 15 years from now, we get better. America, the world gets better on stem cell technology, and it does regenerate disc spaces. It does turn back the clock. To be fair, in the hips and the knees and other joints, stem cells have a little bit of a better track record, but in the lumbar spine and the disc, we just don't have that yet. I'll do a couple more questions. I was kind of saying that I have to go wake my kiddo up, and we got to kind of continue about our day. Angela's asking my thoughts on spinal cord stimulators. Mixed. I'm a little biased. I usually see patients when they don't work, and so there's probably a whole huge cohort out there when it does work. But why would I see those patients if they're doing good? They're doing good. For Marcus, orthodox refer to PRP as voodoo medicine. Yeah, I kind of think that also, but I also openly will say, look, voodoo medicine's not terrible, is it? Like, as long as you as the patient think it helps and makes you feel better, it doesn't matter what it is sometimes. If you think sitting out in the sun for 30 minutes a day makes your back pain feel better, maybe it does. And if it makes you feel better, then fine. So I just don't want people spending tons of money for PRP when there's PRP has a little more evidence than stem cells, and that's just kind of my thoughts on that. And I hope that doesn't make me a villain for telling people not to do it. I'm saying, look, if you got the money, if you want to really avoid surgery, if you want to mentally know you've tried everything, then do it for sure. Marcus, keep asking that question. I apologize. I don't have the answer to that. Sorry, I should have gotten you there. Someone saying stem cells is great for multiple sclerosis. I'm sure it does. I'm not at all saying it doesn't help with multiple sclerosis. I just, oh man, South Carolina just had a crazy run. Fantastic. Fantastic. Um, in terms of stem cells helping other conditions, I'm sure it does. I'm not at all saying it does or doesn't. So I'm just talking about for that. From Buddy, you're seeing a friend of mine, Dr. Koenig. I think he's fantastic, by the way. What are your thoughts on thoracic issues, stenosis, bulging disc? Look, in the thoracic spine, the rib cage, it's pretty rare to have stenosis. not uncommon, but kind of rare. So you could have little disc herniations in the thoracic spine. That doesn't mean it's causing you an issue though. And you're like, oh no, my back hurts. I have disc herniations. Okay, you might. I'm not saying you don't, but I wouldn't hyper focus on that. There could be something else causing it. You have to have a lot of stenosis, a lot of tightening of the thoracic spine for it to be causing myelopathy or things like that. Okay, I'm gonna do a couple more questions. Then honestly, it's burning up back here, and I kind of want to go because I like jumping on here, and we'll just do from there. Any thoughts on a heating pad for spondylolisthesis? That's probably fine. Heating or cooling is fine. I had a fusion. Um, I had a fusion, 2 surgery in 4 months. Now I can walk in bed all day. I'm sorry. I'm reading it word for word. It doesn't make sense. If you can just say that again, Stanley. Maybe just type it one more time. From Tammy, would you fuse a grade 1 spondylolisthesis stenosis at 4 or 5? Maybe. Probably not. I kind of made my reputation and career early not fusing spondylolisthesis for stenosis because I use this thing called an ultrasonic decompression tool, and it's a very efficient way to open up the nerve tunnels. It really just depends on that grade. If it's unstable versus stable, kind of knowing the patient. A instability of the spine is an indication for a fusion, but you don't have to do a fusion. I know that doesn't 100% answer your question, but I'd probably tell you if I had to tell you just from that one comment, probably want to do a fusion. Your spine surgeon might be doing a fusion, and they probably know. I mean, they do know way more about it than I do. So don't go tell them you saw someone on social media that said they wouldn't do a fusion. That's not, I haven't seen your images. It really is. I'd have to see. From Vegas Bill, I apologize. I don't have a recommendation for you. Brian's asking about the Via disc. Little mixed feelings. It's still in its infancy. It's just something where I would recommend a spine surgeon doing spine surgery. From Kristen, I will go look at your question. I'm sorry I missed it. Let me go up a little. Kristen said, also, I did injections in my neck. I had a bad reaction. I can't do an injection anymore. Okay. I think you probably had a comment before that, I'm guessing. You said, another thing you said, I'm in Oklahoma, so it's close to me. I'm in Dallas. I've had CT done 4 times since my fall. I have a lot of questions up here. I'm sorry. My C3-4 compression fractures and thoracic are compression fractures. Okay, you're also saying you had a seizure 2 months ago and fell down a bunch of stairs. Oh my gosh. You have spondylolisthesis. I'm scared what to expect. Okay, so Kristen, there's obviously a whole lot going on there. The part of these comments I've read. So I would just say you shouldn't be scared. You should just, it's kind of like going to maybe Best Buy to buy a TV. You're just seeing the options. That doesn't mean you have to go buy a TV. I usually sometimes say car dealership, but those people are pushy and they want you to buy a car. And I don't want you to say that about a spine surgeon. But look, it sounds like you got an issue. If you're scared to go see the doctor, well, I would just recommend going to see the doctor. It doesn't mean you have to do any of those things. It's just having the information is good, and hopefully that calms your fears. Just having the information. From Stanley, said, yeah, this fusion in the back and you can't stand and you're in bed all day. Well, I'd love to know kind of why or what your preoperative conditions were, and we'll kind of go from there. From Tara, she's saying I had a spine surgery and she's in more pain now. I hate to hear that. That's not good to hear. I just want to know why. Sometimes every now and then, it's not too rare that a spine surgeon, such as myself, we do a fusion at L5S1, and the bone has just been so collapsed, so bone on bone, that when you open it up, it's called a reinnervation pain. It's almost like it's kind of like all the micro stuff go to the nerves, you get blood flow to the nerves. The nerves are waking back up at L5S1, and when that happens, that can definitely lead to these nerves waking up and causing pain. And that's something that's called an L5 palsy. It's something called reinnervation pain. And that's something that could happen at L5S1. Kid scoliosis and pectus. Yeah, I don't treat that. I apologize in terms of the pectus issues, and kind of looking at a couple more things. All right, everyone. Well, look, I have to jump out of here pretty soon. I just want to thank everyone for chiming in. I'll jump on here maybe tomorrow. If you put on a subscription, I think it gives you an alert, and it will it'll let you know when I'm on. So I appreciate everyone kind of following, listening in. I do have to go, and So I'm watching a couple of the end of these football games right here. And also I have to go. I like to do things except for this, but love to just kind of connect to people and give some information.